Hello, everyone, and welcome to today's live webinar, Point of Care Ultrasound Benefits and ROI for Primary and Urgent Care Practices. I'm Shelley Gunther, Clinical Marketing Manager here at Clarius. We're really excited to welcome emergency physician, POCUS educator, and founder of Hello Sono, Dr. Tatiana Havryliuk, and we thank you, our American audience, for joining us for an important discussion on best practices for documentation and training and how to optimize reimbursements with point of care ultrasound, or POCUS. Ultrasound is a time and cost efficient imaging modality that offers a wide range of benefits, including improving patient care and healthcare cost savings. POCUS can also bring in added revenue to your hospital or primary care facility, but how do you, the POCUS user, go about setting up the optimal program for your facility? Dr. Havryliuk is about to share her guidance and strategies for leveraging POCUS in your facilities. I'll be hosting today's webinar, and I'd like to start by sharing a couple of papers that really speak to the value of POCUS and what it continues to bring to healthcare. Now, this first paper talks about, even though point of care ultrasound has shown to augment physical examination and expedite care and clinical decision making, the use of POCUS in internal medicine appears inconsistent despite the benefits that it can provide. Over 90% of internal medicine residents in a community-based hospital identified a lack of formal POCUS curriculum as a major impediment to obtaining the necessary skills for modern practices and training. There are perceived high costs of ultrasound equipment purchases, and paradoxically, POCUS use is associated with significantly reduced healthcare costs, about $20,000 per critically ill patient requiring an ICU stay. And the authors go on to describe the barriers to implementing POCUS programs for internal medicine, including billing complexity, image archiving, and most importantly, the lack of POCUS curriculum for internal medicine residents. And with the right training and proper healthcare facility implementation, could potentially drive innovation, for healthcare systems, especially in resource-limited settings. And this next paper is from a primary care journal, and the authors talk about how many benefits of POCUS, including soft tissue assessments. With all of these benefits in mind, we know that POCUS has been widely adopted by emergency medicine and critical care. And with each technological advancement that ultrasound makes, the breadth of clinical adoption grows. Handheld devices are now bringing bedside ultrasound to primary care clinic settings, and they predict that primary care is poised to become the next field of medicine to adopt POCUS widely. So how are you going to make that work in your facility? Before we get started, I'd like to ask a question so that we can better understand our audience. What are the barriers to having a POCUS program at your facility? Is it that you need more training? Is it all about the funding? Are you just worried about litigation? We'll give you a couple of more seconds to complete the poll. 3, 2, 1. All right. Boy, a lot of it is about the training, and the next one is funding. So I think Dr. Havryliuk is going to have some really valuable information for you here. So without further ado, let me introduce our guest, Dr. Tatiana Havryliuk, an emergency physician, formerly ultrasound director at the Brooklyn Hospital and founder of Hello Sono. Throughout her 15 years of clinical practice, she has relied on POCUS to make informed clinical decisions, whether it was in an urban ED, urgent care, or Everest Base Camp. Dr. Havryliuk is now on a mission to extend the benefits of POCUS to primary care and urgent care practices by addressing the key barriers, the lack of POCUS competency and infrastructure. She and her amazing team at Hello Sono offer in-person provider training and support with credentialing and implementation to build high-quality, compliant, and profitable POCUS programs. So Dr. Havryliuk, I will hand the mic over to you.
Hi, everyone. Shelley, thank you so much for such a warm introduction. I'm super happy to be here sharing with you all my expertise on how POCUS can really benefit your patients and your practice, and also hopefully bring some revenue and return on investment. A few more things I wanted to share about myself before we move on. I actually did a wilderness medicine fellowship first. Then was an attending for a few years, and then went on to do an ultrasound fellowship. And now here I am in front of you, kind of going full circle and sharing my expertise. So ultrasound can really change your management of your patients. I have practiced ultrasound in urgent cares as well, and in various global health settings. I speak at national, international conferences, and also teach POCUS workshops. Uh, I am passionate about POCUS excellence, adventure, dark chocolate, if anyone is looking to send me some gifts, and skiing.
Woman after my
And
own heart.
This is Everest CR at Everest Base Camp, and it's at 17,000 feet in Nepal. And I spent 2 months, a little bit over 2 months here during a climbing season. I actually slept in one of these yellow tents kind of in the background that you see, and it was 5-star accommodations. I loved it. And the reason why I'm sharing this is actually we had POCUS there, and that was our only diagnostic imaging tool. We used it quite a bit. And this is me performing a renal ultrasound on a patient with flank pain who ended up having infected urine on a urine dip. And when I did an ultrasound, I found moderate hydronephrosis. So I was immediately concerned for an infected stone, which could make this patient septic very quickly. I treated him with IV antibiotics and was able to get him on a helicopter within 2 hours and get him to definitive treatment. And we had so many different use cases there, even pregnant women trying to climb Everest. You know, STEMIs, we had gallbladder pathology. So definitely respiratory, looking for high altitude pulmonary edema. But the reason why I'm sharing this is because that's when I really truly understood the value of ultrasound and how it really changed me as a clinician, because I was able to make more informed decisions and better decisions for my patients. And that's how really my whole journey with POCUS started. And this is just the reality of practicing POCUS at 17,000 feet, where the temperatures were freezing most of the time. So we actually ended up having to do hot water baths for our gel almost every morning. All right, so today, first of all, we're going to start off discussing what is really POCUS, making sure we are all on the same page, and why do we care about it right now. And then we'll go over some of the use cases for primary care and urgent care practices, and really discuss the impact of POCUS on patients, the provider, and also the practice. We will go over some of the barriers, and we are seeing that the biggest barrier here in this audience is really, achieving that competency and the use of this tool. And also, I will share some of the strategies that I have discovered over these years on how to implement a successful program. And then finally, we'll discuss the ROI of a POCUS program. So what is point of care ultrasound? It's a clinician performed ultrasound that's done at the bedside. And it's really meant to be a quick exam, so 2 to 5 minutes. It's not a comprehensive ultrasound that an ultrasound tech does and sometimes can take 15, 20, 30 minutes. That's not what we are talking about. So it's meant to be quick. It's very focused. You're answering a specific question to make a clinical decision on the spot so that you can move on quickly and efficiently. And the cool thing that it's a very teachable exam. There's plenty of literature showing that it's very teachable for medical students, for mid-level providers, residents, pre-hospital staff. So much usage and really accessible. And of course, it's also billable, and that's why we are here. Partially, that's why we are here. It comes with its own limited ultrasound CPT codes. So if you are in fee-for-service contracts and those CPT codes are in your contract, you should really be billing for it as well. And these are kind of just the sizes and the shapes of the POCUS devices out there. A lot of us are really familiar with the card-based systems that we encounter usually within the hospitals. And then there are these laptop systems that we use at Everest. And now over the last 5 years or so, we are seeing these handheld systems that fit in your pocket. They work with your phone or a tablet, and it's super cool. You can take them really anywhere. So why do we care about it now? Well, number one, these handheld devices, they are a lot more affordable. You can get quite a good device, anywhere from $3,000 to $5,000. And in the past, you would have to pay probably 40K for it, for one of those card-based systems. So the price has gone down quite a bit. There's also a ton of evidence from emergency medicine literature, ICU, internal medicine, and now increasingly primary care literature showing the benefits of ultrasound on efficiency, on making informed decisions and diagnostic accuracy, and also cost savings. And I'm just going to give you one example over here that stands out for me. There was a study done on emergency physicians trying to determine whether IND was indicated on patients with soft tissue infections where an abscess was not obvious. And guess what? 56% of the time, ultrasound changed their management. So they might have been doing an unnecessary, painful procedure and also spending time doing it when it was not indicated, for example. Or on the other hand, they were not doing a procedure when it was indicated, right? And that means that the patient probably had to return to the ER to have that abscess drained eventually. So you can see the impact right there. It's also now backed by key organizations from ASAP to AFP to ACGME. So ACGME actually put out a statement last year recommending for all family medicine residents to get POCUS training actually during their residency. So there are huge shifts that we are seeing in resident education. And the very cool thing about ultrasound is it fits perfectly into value-based care model. It is very much patient-centric. It improves care and efficiency, and it also brings cost savings by avoiding ER visits, by avoiding more expensive tests, and also by giving more appropriate treatments sooner. And finally, for those of you, especially in urgent care practices, who are facing the radiology tech shortages, I mean, that's a real thing. You can have your own providers trained in this diagnostic modality that can a lot of times replace X-ray. And I'll give you some evidence on where ultrasound and how ultrasound can be used next. But first, here's a little case for you. And of course, it's 5 p.m., it's Friday, you're in your urgent care, and you got Mr. Google come in, and he's 56, he's a healthy guy, and he's having one day of left calf pain. He's a business person, and he actually says that he flew from LA to New York 3 days ago, and he has a flight he needs to catch back to LA tomorrow. So he wants to know if there's a clot and whether he's safe to go back on a flight tomorrow. Sounds familiar? I can't see your hands, guys, but I'm sure you had a case similar to this. On his physical exam, the only thing you're encountering is some mild tenderness to the calf, nothing remarkable otherwise. And of course, if you have no POCUS, what are you going to do with this person? And it really depends on your comfort level with risk, on your prior experience, and on your capabilities and your urgent care. Do you have a high sensitivity D-dimer that you can get results for in an hour, maybe a couple of hours, like that same day, right? Because that patient can probably be ruled out with a D-dimer. He's low enough risk. But say you don't have that capability, or your D-dimer comes back in 1 or 2 days, right? And this guy is going to be in LA tomorrow. Or maybe you're not sure whether this person would follow up and get an ultrasound, even if you ordered him say 2 days from now. So I think there's a lot of variability and uncertainty, and some people will just send this person to the ER because to get a Doppler there, and who knows whether it would be a Doppler there. So no matter what, your patient is not going to have an answer. He might be risking waiting in the ER for a couple of hours, and also having a huge bill afterwards, or you can do a 2-minute compression test of his vasculature of proximal extremity and really rule out a DVT for him. And if you add a D-dimer in addition, and in 2 days, the D-dimer is negative as well, this patient, you don't need to do any further testing for this patient. So I think that's where POCUS can really change the way we practice medicine and the way the patients experience medicine. And this is just a demonstration of what a normal and abnormal vascular study looks like. So on the left side over here, you see a fully compressible vessel right here. That's the vein. The arteries are not compressible, but it was compressible. On this side over here, these are two non-compressible vessels. So the artery is not supposed to compress, but the vein should be compressible. So if you are not able to compress the vein, then it means there is probably a clot there. So this is how easy it is to visualize a clot with compression ultrasound. And we'll have a live demo for you guys in the end. So what are some other common uses of POCUS in primary care and urgent care? So we already discussed a patient with leg swelling or pain. Not only can you rule out a DVT, you can actually look for Baker's cyst, right? So say you do see in that patient a Baker's cyst, and now you have an explanation of why he's having that calf pain. Ultrasound is great for soft tissue complaints, whether it's identifying an abscess or cellulitis, or looking for foreign body. In fact, ultrasound picks up foreign bodies that are wood, plastic, glass, the stuff that X-ray can't see. So it's really cool. And another thing you can do with ultrasound is you can actually see how deep your abscess is, how big it is, whether there is any vasculature in the way of you superficial to the abscess where you're going to be doing IND. Anyone seen patients with cough or dyspnea? Okay, once again, I can't see your hands, but I'm sure you guys are seeing a ton of those. And I mean, one of the things I really want you guys to get out of this session is that ultrasound is so much better than chest X-ray at identifying all kinds of lung pathology. I'll give you a study that just came out this year, and it's a Canadian study. It was a review study looking at comparing chest X-ray to lung ultrasound and pediatrics, adult, and elderly population. And basically, the overall sensitivity for pneumonia for lung ultrasound was 86% versus for chest X-ray, it was 64. So 86 versus 64, huge difference. And it just beats me why we are not using lung ultrasound as our primary modality to look for lung infections. Ultrasound is also better at diagnosing pneumothorax, looking for CHF exacerbation. It's great looking for COVID as well. So I really encourage all of you to explore that a bit further. In patients with chest pain or dyspnea, you can look at their ejection fraction. You can rule out pericardial effusion. Patients with flank pain and hematuria, there's another great ER study. It was a big study. It was, I believe it was in New England Journal of Medicine, where they did a POCUS first approach for patients with potential renal colic, and they ended up avoiding 60% of the CAT scans that they were going to order. And not only that, they also increased their throughput in the ER, saved a ton of money, and also saved radiation to the patients. So it's really something to consider if you're seeing quite a bit of patients with kidney stones. So when you're looking for hydronephrosis in that case. Patients with decreased urination or suprapubic pain, you can look for urinary retention by measuring bladder volume. Patients with upper abdominal pain, you can look for gallbladder pathology. And oh my God, ultrasound is so good at looking at musculoskeletal injuries. And it goes from joint effusions to tendon tears, tendinitis, fractures, dislocations, muscle hematomas. And it's really cool because you can really do it on the spot. You can exaggerate the actual injury and to really see how bad the tear is, for example, stuff that you can't really do with MRI on an X-ray. So I really encourage, once again, to do more MSK ultrasound. And my last category here was the procedural guidance. Ultrasound guided IVs, joint aspirations or injections, foreign body removal. IND, all of that is really within the realm of primary care and urgent care, and ultrasound can make your life so much easier for those procedures. And this is another example of how simple it is to see pathology with ultrasound. So on the left side over here, we see a normal kidney that has hyperechoic or bright white center. That is normal. And on the right side is a kidney that's not normal. So the center of it is actually anechoic or black. Uh, and that signifies that there's fluid in the pelvis and it's actually distending into the calyces. So you're seeing the fluid this kind of extending a little bit. That demonstration was some normal kidney versus kidney with hydronephrosis. It's quite simple to tell on ultrasound. And now that I really talked it up and showed you some use cases, I really want to discuss the impact of ultrasound on the patient, the provider, and also the practice. So for the patients, well, number one, they get to avoid radiation, which is really important for children. If you're seeing a lot of urgent cares are seeing pretty large volumes of kids and also younger adults. And then they also get to understand their diagnosis better because they get to visualize it a lot of times. And they also get their doctor at the bedside for maybe a few minutes longer so they can have a little bit more conversation about their condition. That also develops trust between the provider and the patient. In fact, there was a primary care study done that showed that 65% of the patients who received POCUS trusted their provider more because they received POCUS from their provider. And then there are cost savings for the patients by avoiding ER visits, avoiding more expensive imaging, and also hopefully avoiding days missed from work, right? That's really important for some patients. And then they're also developing loyalty for your practice because you're giving them this service that is not very common in other practices yet. And what is it for a provider other than having increased trust with a patient and a better relationship with a patient? They get to develop a new skill and a skill that's marketable and transferable, and they get to keep up with the standards, new standards in medicine. And another thing, as a clinician, I'm going to say you get to avoid a lot of frustrations, but being able to do POCUS for various reasons. Sometimes it's that DVT case where I would rather just tell the patient, hey, you don't have a DVT and kind of move on and reassure them. But also, I, as a clinician, don't want to deal with the whole follow-up process. So now I'm stuck with a patient. I don't know whether it's a DVT. I need to schedule an ultrasound for this person. Then I'll need to make sure they actually get the ultrasound. Then I'm going to call them with the results. And then I'll also have to act potentially upon the results, which takes a lot longer than a 2-minute ultrasound. So I think for me, it saves me a lot of that frustration and time as well. And I'm going to argue that ultrasound really decreases liability because now you're making more informed decisions. You're starting patients on appropriate treatment sooner, and you're also having some of your procedures are becoming safer because you're using ultrasound for guidance. And finally, what is it for the end? What's the impact on a practice other than some overall cost savings for a healthcare system? They are developing loyalty with the patients, decrease liability. They're also introducing a new service and a differentiator, and hopefully that will attract new patients and also cause retention of the current patients. And there's an opportunity to increase revenue, especially if you are in fee-for-service contracts and you are able to bill for your ultrasounds. And I think the most important and kind of the overarching impact of POCUS across all of these categories is really what we all want, right? Better patient care and also efficient care. And I'm really a big believer that POCUS does both of these things really well. All right, guys. Well, now that I shared all this exciting information, I also want to touch a little bit more on the patient experience. And this is a study from primary care. This is a Scandinavian study, and they had over 800 patients in this study. And what they found is that patients 92% of the patients reported they felt more thoroughly examined when ultrasound was used, which makes sense. And I think it makes so much more sense than someone putting a stethoscope on your chest versus doing actual ultrasound and seeing what's going on internally and showing your patient what's going on. I think there's a huge difference. And also 95% of them felt that POCUS improved the level of service they were receiving. And that's really important, right? Because nowadays, and whether you're in primary care or urgent care, the number of stars you have on Google reviews can really make or break your business. So I think it's so important to have this additional service you can offer that can potentially improve the patient experience. And this is another thing I wanted to share from a recent study from New York Presbyterian, and it was an internal medicine study where they described what they called a POCUS positive care effect. But basically, it was a placebo-like effect among inpatients who reported, once again, increased trust in their providers because they received POCUS, and also overall better experience, like hospital experience, just because they received POCUS. So lots of food for thought over here. And I'm also happy to share all the references I have made. You can just email me or send me a message on LinkedIn, or I can get it to you somehow. So now that I really talked it up and I told you about all this impact and all these use cases, why aren't we all doing it? And we saw the poll results, right? So one of the big barriers that we identified in this group is the lack of competency. I have some other ones I'd like to share with you that I've discovered while working with the clients. Lack of awareness is a big one. And I'm talking about awareness among the decision makers. They might be non-clinical, or maybe they were clinical, but they're kind of further removed from it. So they might not know all the advances and POCUS industry and also the literature that's out there. And that's one of the reasons why I do these webinars and also go to speak at conferences, is to get in front of the decision makers and make them aware of this tool. The competency piece, definitely, that's something that's not everyone was lucky like myself to get POCUS and medical school residency and do then a fellowship in it. But I don't want you to feel discouraged, because there's also a ton more resources than there have ever been in POCUS education, whether it's online education, in-person courses. Hello Sono offers custom CME courses, but there's a ton out there. Almost any conference you go to right now, you can do some kind of workshop on POCUS. So I really encourage you to kind of explore and see what's out there. No funds, that's also something that you guys all mentioned and then does come up. The good news is the device is a lot more affordable. So I think this is a bit less of a barrier than it used to be even 5 years ago. Too complicated. I mean, it is a little bit complicated. There are guidelines that exist, but they are extensive and they do keep changing. So, and that's kind of the point of this lecture, is to give you a little bit of a framework of what you need to look at to make sure you are building a compliant program. And that's really coming up in my next slides. Litigation concerns. That comes up once in a while. And I think there is a certain fear of misinterpreting a POCUS image and somehow getting into trouble. And part of it is, we are not radiologists. Why are we doing ultrasound? That's kind of the argument that I get sometimes. And I really want you to remember that this is meant to be kind of the first step in patients' workup a lot of times. So we are not replacing a comprehensive ultrasound. Sometimes we will decide to forego a comprehensive ultrasound because we found our answer, or we would like the patient to get a CAT scan instead of that ultrasound, right? But it's just making our decision more precise and more beneficial for the patient. And also, there's quite a bit of review articles looking at malpractice cases where POCUS was implicated. And the most recent one I found, there are studies both in primary care and emergency medicine literature. The most recent study I found had 8 malpractice cases where POCUS was implicated. And None of them were because the provider misinterpreted the image. The issue was that they didn't do POCUS when it was available, or they delayed it when it was available. So really, it just highlights how important POCUS is in patient care, especially in critical patients. Um, it can give you so many answers on the spot and really guide your decision making and management. Other priorities, I can't argue with that. If you have a lot going on in your practice, uh, initiating a POCUS program might not be the best time because it is kind of resource heavy and it's time consuming in a way, right? There are certain steps you need to follow. You need to build out a workflow, train your providers. And I would say you would need probably 6 months to a year, depending how extensive you want your POCUS program to be. So kind of think about dedicating some good effort and time if you're looking to build a high quality POCUS program. So now that we've discussed the barriers, I'd like to share with you some implementation strategies and really 10 key components you got to think of when you're putting a program together. Number one, super important, is to have a POCUS champion. If you are in a residency program, it could be a POCUS director, but really someone who really believes in technology and this tool, and it can also be a resource to others who are learning it, or someone who knows what to do when the probe, say, is offline or something, or is broken, right? They know how to get in touch with biomed or the right IT people. They also know your credentialing protocols, or at least they can point to them. So if you have a new person coming on, they can reference that. So really important to have the POCUS champion. I would strongly encourage all of you to involve your IT and biomedical departments early on in the process, especially if you are part of a bigger healthcare system, because they do have a lot of say in this. And a lot of times they will end up maintaining your devices and kind of maintaining the workflow you have. So it's important to have their buy-in early on. Then you got to select your devices and also figure out how are you going to store all of these ultrasound exams, and also have some kind of QA solution, especially in the beginning when you're still training your providers. And when you're selecting the devices, there are a couple of things you want to consider: portability, you want to consider your budget. Obviously, you need to know what kind of scans you're going to be doing, because that depends what kind of probes you need. You're going to have a lot of novice users who might benefit from all that AI technology and AI help. So there are lots of different considerations. Another one is kind of compatibility with various devices: iOS compatibility, Android compatibility. Do they work both on tablets and phones? So all kinds of things to consider before you kind of commit to a device. And then some of them also come with some cloud storage capability and some basic worksheets, for example. And some of them don't, right? So you need to figure out what you really want your workflow to look like before you commit to a particular solution. And you can store, this comes up a lot, if you have a PACS system, you can store your ultrasound images in PACS, because a lot of urgent cares do have PACS. The thing is, if you're first training your providers, you want to kind of siphon off the educational scans in what we call a middleware, or some kind of cloud where they are not showing up in the EMR, because they're just educational scans. And they're used to kind of credential your providers and make sure they're obtaining quality scans. You got to have protocols and clinical pathways in place, and the protocols I am referring to are your credentialing protocol, infection control protocols, use of handheld devices, like outside handheld devices, personally owned handheld devices on the patients in your facility, right? So that can actually become very confusing with billing if someone brings in their own device. And I certainly encourage you to have clinical pathways so that the providers are using POCUS within its limitations. You don't want the providers, say in an urgent care, doing abdominal scanning on a patient who's 80 years old with flank pain, right? Those people should be going to the emergency room to get a CAT scan and further evaluation, not POCUS in urgent care. Documentation, you'll need to decide so a lot of times you can create templates in your EMR for POCUS procedure notes, and I'll let you know what's in the procedure note in one of my slides coming up. And then after you kind of have your workflow set up, you figured out your credentialing protocol, you have your devices, then it's time to make sure your providers have undergone your credentialing process so they are competent in ultrasound. And my next slide will cover kind of what's recommended for the credentialing. You should have a quality assurance process in place to make sure the quality of your provider scans stay high. And then your providers should also obtain privileges, especially if they are if you're part of a bigger healthcare system. You need to basically request privileges to be doing POCUS, diagnostic POCUS on the patients in your institution. And honestly, after that, that's when you should start billing. When kind of all of your I's are dotted, all of your T's are crossed, that's when you're going to have billing that's compliant. And if you do ever get audited, you will have plenty of documentation showing, hey, we're storing all of our images, all of our providers are credentialed, this is our credentialing guidelines, we have a QA program in place, and that's when you stay out of trouble. And unfortunately, there isn't really a guideline from CMS right now or from a private payer that will tell you exactly the steps you need to take at this point. So what are some of the provider credentialing guidelines? And this is based on ASAP and AFP, but basically there are kind of a few components that you got to consider. Number one, there is kind of this element of passive learning or asynchronous learning, and that's usually consuming online content in a video format, maybe doing some questions, ebooks. There's plenty of material out there. Some of it comes with actual CME, and I do encourage, if you can get CME, do the content that gives you CME so you have proof of what you've done in terms of your education. It is highly recommended to do a hands-on workshop, either 1 or 2 day workshop, although you could replace it with SIM and kind of like teleguidance. I don't think they're equivalent. I do think if you can, I would opt for a hands-on workshop if you are a new user of POCUS. And then there's this period of preceptorship, and preceptorship can last anywhere from 3 months, I'd say, to a year. If you're in a residency program, it's 3 to 4 years, depending how long your residency program is. And really the preceptorship is this period when your providers are collecting educational scans. So those scans are done on patients, or maybe they're friends, but or family, but they are not being used for clinical decision making. So they're not going into patients' chart. They're being stored in that cloud that we talked about, or the middleware, where your providers are submitting, little procedure notes, or what we call the worksheets, for their interpretation. And then there is a qualified person that's reviewing those scans and giving them feedback to make sure that they are obtaining quality scans, appropriate images, and then they are interpreting them correctly. And it is recommended that a minimum of 25 scans of each exam type should be done to basically achieve a certain competency level. So if you're learning long ultrasound, DVT ultrasound, say, you'll need to get 25 of each, and then have them all reviewed before you can actually perform them on a patient for diagnostic purposes. And for procedural ultrasounds, you only need 5 to 10 to kind of meet that criteria that ASAP put out. It's a good idea to have some kind of assessment, whether it's OSCE style at the bedside. You can also have the providers do some kind of multiple choice exam online, for example, a question bank. And also you can look at their kind of the quality of their scans that they've been submitting. Are they getting a ton of false negatives and false positives. If they are, then maybe they are not ready to start getting doing diagnostic scans, and they need to collect more studies and improve their accuracy before they can go on and scan patients and make clinical decisions. And then you've got to also have an element of how they're going to maintain it. And usually that consists of some kind of CME requirement, a certain number of scans they need to perform each year, and also that QA process of having some of their scans being sent to be being reviewed by an expert to make sure the quality is maintained. And in this section, a lot of times what comes up is a question about certifications. What is certification versus credentialing? ASAP put out a statement that they do not believe that people need external certifications, because anyone can give you a certification. It depends how you need to know how rigorous it is and what are the requirements. So it's really hard to tell when someone is getting external certification how valid it is and how reflective it is of the competency. So I think instead of getting certifications, although sometimes it makes sense, but really focus on developing competency and doing this, collecting those educational scans, and also getting CME while you're doing all of that. So here are just some requirements for billing, storage, and documentation. These are billing requirements. So number one, you should really have an order when you do POCUS. And although it's not actually required, it just clues your coders in to look for a procedure note. And if they don't see a procedure note, they will let you know to put in a procedure note because you ordered the test, so you were planning to do it. And another requirement is to have indefinite secure archiving, so HIPAA compliant archiving of your images. And then you should have a procedure note, and a procedure note should kind of have the typical stuff: who did the scan, the referring physician, a timestamp, what were the indications for exam, what views you obtained, what findings, and what your final impression was. So kind of the typical radiology style procedure note. And it can be quite short. And then finally, very importantly, you got to put in medical necessity in the MDM section of your note. Why was this indicated? Some additional considerations in practices that are just bringing it on and they don't have a lot of experienced providers with POCUS. So number one, I think it's really important to have strict clinical pathways. So the narrower the pathways, the clearer they are, I think the better the adoption of this will be. And once again, like as I mentioned, you don't want your clinicians in urgent care to be doing POCUS on 80-year-olds with flank pain, right? So that just, they are wasting a lot of time, and they are not doing a test, and they are not acting within the limitation of the test. So think about that. Another pointer is to pilot first. If you have multiple sites, maybe do it at a few key sites first, and then iron out the kinks and kind of introduce it to the other sites. There's an option for that SIM and teleguidance. If you're not able, maybe your patient volumes are not enough to get those educational scans, or you really need, you're not able to get that CME hands-on course, for example, you can do a teleguidance. You can have a teleguidance option. I encourage everyone to collect data, especially around patient satisfaction, ER referrals, any kind of revenue. And that's really helpful to also go in front of your administrators later on when you want to buy new devices or get more training for your providers. It's really important to show that with the data, like this is the impact that POCUS is having on our practice and our patients. And then finally, I have quite a few practices that were able to get grants to implement a POCUS program. So if funding is an issue for you, that's something that's great to look into, because it really fits so well into value-based kind of care model. So what is a robust POCUS program? And those kind of the 4 components I identified. Number one, I believe it needs to be compliant, and I mean compliant with your own internal protocols, kind of your state also regulations around, for example, mid-level supervision doing procedures, or also compliance with the guidelines from ASAP, AFP. So consider all of that when you're building your program. I think a focus program should be seamless, and here I'm talking about workflow as seamless as possible, right? Make it simple for your providers, because if it gets too complicated, they just got to skip it. So if you can not have too many logins, if you can have your images be transported wirelessly into PACS or some kind of storage, that's going to simplify the process for everyone. Of course, a robust focus program should be of high quality. And here I mean the competency level of the providers. They need to be skilled in this tool, and also the quality assurance process needs to be in place. And finally, I truly believe that a focus program should be profitable. I think there is an overhead investment, and we'll discuss that later, right? But you're buying the devices, you're training all of your providers, and you're also delivering a better patient care to your patients. And there are CPT codes that come with POCUS. So it just makes sense to be able to bill for this and at least bring in enough revenue to kind of pay for the POCUS program. So that brings us to the ROI. I kind of think of three different elements when I think of ROI. The first is the practices in fee-for-service contracts. So the ones who can actually bill for POCUS directly, so call it direct billing, right? You put in a procedure note, there's CPT codes attached, and you get reimbursed. And say you're still in fee-for-service contract, but the CPT codes are not in your private payer contract. Then you can actually use POCUS to increase your E&M code complexity. So you can put in that statement in medical decision-making part of the note saying, I performed and reviewed diagnostic images independently. Kind of what we do with x-rays sometimes. And then there is this more kind of indirect category of how ultrasound POCUS can bring you revenue. And there are a couple of components. You're providing safer and better care, so your quality metrics are up. You're more efficient, so hopefully your providers are able to see more patients because they're more efficient. They are not doing unnecessary INDs or follow-ups that take potentially, 5-10 minutes of phone calls. Instead, they can see a patient. You're building loyalty with your current patients. You have a differentiator and also expanded services that are hopefully attracting more patient volumes for you, and that indirectly translates into revenue. And then finally, kind of the third element I think of is the overall cost savings for the healthcare system, for the provider, and also if you're in urgent care that's struggling with kind of retaining your x-ray techs, ultrasound techs, and maybe your volumes of x-rays are not huge. If your providers are trained in POCUS, maybe you don't even need an x-ray tech at that point. It's like a lot of things you can do with just using POCUS. So I'm going to kind of throw in some numbers over here to give you an idea of what reimbursement to expect. Before we do that, I just wanted to discuss what non-facility versus facility type of practices are for the clinicians out there who might not be as familiar. But basically, if you are a non-facility practice, that means you're not fully attached to a hospital. That's usually most of the urgent cares, most of the independent primary care practices. You can bill for kind of a global fee. That means you can bill for professional and technical components. So this is ideal because this is where you can get reimbursed the most for POCUS. And then there are facility-based practices. So that would be a department within the hospital. For example, a hospitalist group or emergency medicine group, or maybe an outpatient department that's attached to the hospital. So those places, because they are facility-based, they will only be able to bill for professional components. and the hospital will kind of bill for the technical component. So these are Medicare nationwide fees for 2024. And basically they range from lung ultrasound, a global payment is $56, and for a fast is $180. So that's kind of your range there. And then for procedural ultrasounds, you are getting $28 to $57 on top of whatever the cost is of actually doing the procedure. So I kind of put together a, an estimated usage of POCUS in a non-facility practice. And they're doing about two ultrasounds per day, and they're mostly lung ultrasounds and soft tissue MSK, as you can see over here. And basically their billable amounts would be almost $6,000 a month, or it comes out to $70,000 annually. And those are for physician performed exams. And this is assuming that they are in fee-for-service contracts, right? So if you are not in fee-for-service contracts, or you're 50% of your contracts are fee-for-service, then you would have this amount. But if you're doing 2 ultrasounds a day, your potential is to get $70,000 annually in additional revenue. And if those are mid-level provider performed ultrasounds, then on average, those are 85% of the physician performed amounts. So that would be about $60,000 a year. And yeah, you must consider your individual payer contracts, obviously. And a lot of payer contracts will pay a bit more than these Medicare fees. And I note I have not included any procedural ultrasounds on here, or ocular, or something more advanced. And then on this slide, I'd like to just give you an idea of what payments look for facility-based practices, so like hospital-associated ones. And this is a mistake, it shouldn't say global payments, because those are really professional fees only. So your professional payments are going to be for DVT annual $20 to ranging to $51 for a fast. So significantly lower, because the technical component is usually the more expensive portion. The technical component includes the equipment, the staff salaries who are doing the actual ultrasound, the rent of the building, for example, the gel that you're using. So that's all part of the technical component. That's why it usually is a lot more expensive than the professional. And for the procedural guidance, so on top of the procedure, you can add another $10 to $29. And I kind of flew through those 2 slides, but if you really want to play around with the numbers, I actually built 2 POCUS ROI calculators on my site. They are free to use, and the first one is for those non-facility practices, so most primary care and urgent care practices. And the second one is for the facility base. And basically, you can put in how many ultrasounds of each type you're planning to use every week. And then you can put in your payer mix, like how many Medicaid, Medicare patients, and private payer patients. And it will give you a kind of an estimate of a billable amount. And I encourage you to use it, because if you're really hoping to implement this is a great kind of numbers you'd be able to go and show to your administrators as well, the potential kind of revenue. So you can only imagine that there would be some reimbursement challenges, because we are in the healthcare field. So I'm not going to spend too much time on this, but it's the obvious, right? If you didn't document it, you can't bill for it. Common causes of denials is incomplete documentation. So someone did a procedural note, but they didn't do the medical necessity part. You also cannot bill for repeat ultrasounds of the same kind of, like if you did a fast once and it's the same provider who did it on the same day, you can't bill for a repeat fast by the same provider on the same day. And then another one, if the CPT codes are not for POCUS and not part of your private payer contracts, you're not going to be able to get reimbursed for those. And then what about these private payer contracts? I feel like this is a whole other kind of lecture we can do on this, or probably 10. But really the idea is that if the CPT codes for POCUS are not in your contracts, or say their reimbursements are really low, then you can go to a private payer and do two things. You can either ask for a carve out, and that depends on your state actually where you can do a carve out, and insert those CPT codes in your current contracts, or you might need to wait until it's time to renegotiate the contracts when they're about to expire, and then you ask for those CPT codes. And sometimes there could be resistance to inserting the CPT codes, and that's when you gotta speak to the medical director and kind of show them some numbers, like, hey, this is potentially how many patients I'm not going to send to the ER if I can do POCUS, and these are your cost savings. And a lot of times they can be convinced to get those CPT codes into your contracts. This is kind of my second to last slide, so I hope I'm not over time. How am I doing on time?
We're almost to the top of the hour here. Yeah.
Okay. I'm sorry, guys.
That's okay.
Well, I'm gonna go fast.
That's good information.
Overhead costs. So you got to think of getting the devices, some kind of archiving solution, at least for the beginning. And then you've got to train your providers and put them through this preceptorship period. So I estimated if you have 3 providers, you're getting 1 device, you have 1 facility that needs this QA solution, it probably would be $18,000 and up for the first year. And then obviously it's going to be a lot, yes, in terms of recurrent expenses, because you would only be paying for QA solution, maybe some additional training. But remember, your revenue on this could potentially be a lot higher, right? What we discussed, 60, 70K. So the key takeaways from today, I want you to remember that POCUS is way better than chest X-ray for lung pathology. There are 10 key components to implementation that I shared with you. I'm happy to share it again. Just reach out to me. And also POCUS adds additional 60 to 70K if you're doing 2 exams per day in 1 facility. So that could be significant for some practices. All right, I'd love to stay connected. You guys, this is a QR code for the POCUS ROI calculator. This is to get in touch with me on LinkedIn, shoot me a message. I'd love to continue conversation. My email and HelloSondo's website. I'm going to give it over to Shelley.
Yeah, thank you. Boy, lots of good information there. We are going to have a live demo in a few minutes, but just before we open the floor to live questions, there's just a quick poll that I'd like to throw out there, because we'd love to help everybody continue their journey in bringing ultrasound into the practices. So please do complete this poll if you'd like any additional information on our 3rd generation wireless scanners, and click as many as apply. And while you do that, I'll just take a minute to share some information about Clarius HD3. It's our 3rd generation of portable wireless ultrasound scanners. They deliver unrivaled image quality across a big variety of ultrasound applications, whatever you're doing. And it's got an easy to use app powered by artificial intelligence, and lots of options for exam management as well. We have a total of 8 scanners to meet the needs across all hospital applications, from eMed and critical care to primary care applications. And our scanners come equipped with artificial intelligence that helps deliver the image quality only found in traditional systems, but at a fraction of the cost. And so that $60,000 that you of revenue, you could buy a whole bunch of them in a year. With AI replacing complex knobs and buttons, it's really easy to use as your smartphone. Clarius is wireless, freeing up space with a 0 footprint for ultra portability in a variety of settings, and you get free movement with no wires getting in the way. And if you're doing procedural ultrasound, no wires touching your sterile prep area. And Clarius is also much faster to clean for this reason, and disinfect. You can fully encase it in a sterile sheath. Only Clarius delivers wireless scanners with an ecosystem that includes a free app for your iOS or Android device for unlimited users. And available with our new membership, Clarius Cloud is available to easily capture, store, and manage unlimited exams and build reports from anywhere. So while you're building your POCUS program, you could easily use the cloud. Your membership includes in-app classroom videos with experts like Dr. Havryliuk and onboarding with a Clarius clinician to build your ultrasound skills. And Clarius Live delivers one-click telemedicine if you'd like to share live scanning with a colleague for a second opinion. I'd also like to highlight the most recent addition to our Clarius family of scanners, the PAL phased array and linear scanner. It's a two-in-one whole body solution with the ability to seamlessly and instantly switch from scanning superficial structures with the linear portion, for instance, vascular access, to abdominal or cardiac imaging with a click of a button, which would take you to the phased array of the scanner. Now we'll close off the poll in 3, 2, 1. Thank you. If you ask for more information, we'll get back to you in the coming week. Just before we start our Q&A, we'd also like you to pre-register for our next webinar, Ocular POCUS, Diagnosing Traumatic Eye Injuries and Avoiding Vision Loss, which will take place on June 26th. Emergency physician Dr. Tom Cook will have lots of content like he always does, including some great cases, along with technical scanning, techniques for scanning the eye. So please complete this poll to pre-register and we'll send you a confirmation in the coming days. I'll give you a couple of more seconds to complete this poll and save your seat. Great. All right. And I think if Janae is set up there, we can switch over and she'll give us a quick live demo and then we'll get to the Q&A session. And obviously we're over the hour here, so please stick around and we'll try to get to as many questions as we can. Thanks. Go ahead, Janae. Thanks.
Thanks, Shelley. So for my live demo today, I will be having a quick look at a DVT study, and I'm using the L7 linear transducer, and I've already selected the DVT preset on my device. So I'm going to start high up in the inguinal canal, right at the crease. And here we can see come into view the common femoral vein and the common femoral artery. And I'm high enough up here that I can see the greater saphenous vein coming into the common femoral vein. And we'll start with a compression here. So we want to see the anterior and posterior walls of that vein fully compress and touch each other. So we've got the vein here immediately on the right-hand side of the screen and the artery on the left. So we'll compress here, fully compresses all the way down. We'll move distally down the patient's thigh, and we'll do a couple compressions on our way down, making sure that those walls touch all the way down. Moving down the leg here. The vein starts to dive posteriorly into the adductor canal, but we can still see it nice and clearly here, and we can see it compressing. We know that we've compressed the vein enough. Our patient here today has a nice, thin, non-edematous leg, but if you do have a patient that has a larger leg, you can place your hand posteriorly on the leg for some counter pressure. And you know that you've compressed it enough when you start to see the artery indent a little bit. If the vein isn't compressing at that point, then you can question pathology versus not enough pressure. So now I'm going to come posterior into the popliteal fossa. Let's adjust my image here. So we can see the popliteal vein right at the center of the image. It's on more superficial than the popliteal artery, so we can compress here. We'll move proximally. Sorry, I'll just bring your leg out a little bit here and compress a little bit moving up. And then also in the distal, we can see the popliteal vein trifurcation there as it dives into the calf veins. So we've successfully ruled out a deep vein thrombosis on this patient. Thank you. So I've got a quick demo here. I've put together a phantom with a few different types of common foreign bodies that you might see in an acute care setting. So I'll change my setting to MSK and I'll start here. And we've got this foreign body that I've embedded into my tofu is a metal. So we can see the reverberation artifact here. And you can see some posterior shadowing. If we freeze the image here. So if we're going to do an extraction, it's good information to know how deep the foreign body is. We can do a quick wet measurement and see that it's about 1.1 centimeters from the skin surface. So again, this is a metal foreign body. And then if we move over here, I've embedded a piece of glass. So we can see that same reverberation artifact posteriorly. The glass appears really bright and echogenic. On this one, we can see a bit of a tapering of the reverberation. So that looks like a bit of the comet tail artifact. And that again is a piece of glass. So we can freeze the image there, do those same measurements if you want to find out how deep it is. And you can also measure the foreign body itself, 0.86 centimeters. And one other foreign body I've got here. So this is a splinter of wood. So a little piece of toothpick. And you can see this one doesn't appear, it does appear echogenic, or sorry, yes, echogenic, but no, you don't see as much of that reverberation at all artifact, just the way that it reacts differently to the sound beam. We can freeze the image here. And again, you can go in with your measurements and plan for an extraction. And that wraps up my live demo today. I'll hand it back to you, Shelley.
Excellent. Thanks, Janae. Yeah, it's kind of amazing how different those things look in there. So I guess once you're familiar with what it is, your patient will probably know what's in there. But yeah, good to know how big these things are and you know, how to scan them properly and be familiar with what they look like. So yeah. All right, Dr. Havryliuk. We'll get to a couple of questions here because we're over, and then I'll just remind everybody that we will follow up with answers to your questions within the coming weeks. So if we don't get to you right away, somebody wanted to know ulnar collateral ligament tears or skier's thumb. Can you see them with ultrasound?
You can see them with ultrasound. You'll need to have a really high frequency probe to do those really small, smaller ligaments. Also, it's a good idea. A lot of times we'll do either a water bath on the hand or having kind of like a piece of a gel pad or liquid to put our ultrasound on top to have some space away from the ligament. So you can see it better on ultrasound, but definitely doable.
Okay. There is a question. Is the handheld ultrasound machine recommended for primary care POCUS? Are the images for handheld adequate for billing documentation purposes?
Yes, for sure. Yes. And I think it is a really great option because it's also very portable and more affordable.
Great. There's a question here about DVTs. When ruling out a DVT, and I think we kind of answered this, but is it recommended to scan the entire extremity or just the area of pain or swelling?
You want to do, at the very least, the proximal kind of leg scan, which is from the groin to the popliteal fossa. And you're compressing kind of the veins as you go along.
All right. And then people are asking for information just about Hello Sono. So I think we can follow up with that after the webinar. Yeah. IUD positioning, is this something we can do transabdominally?
You can, for sure. I mean, you can see IUD on a transabdominal scan. You will also see it when it's out of place. So yeah.
Yeah, okay, great. All right. Okay, well, I think to be respectful of everybody's time here, we'll close for now. So I would like to thank you so much, Dr. Havryliuk. That was really great. And like I said, if we didn't get to everyone's questions, we'll follow up by email in the coming week. And you'll all receive a copy of the slides and a webinar recording as well. And again, thank you so much for a great session, and a very big thank you to all of you for joining us. In the meantime, have a wonderful rest of your day and keep scanning.
Thank you, everyone.